professional care of feet dates back to ancient Egypt. This is about 2400 BC. Hippocrates first described corns and calluses and the need to physically take care of hard skin and its causes. Since then, a lot has changed, and now we have the field of podiatric medicine that takes care of feet and ankles. In Kenya, we have a foot and ankle surgeon who will be taking us through this discussion on what you need to do in order to take extra care of your feet. But first of all, how often do you check your feet?
Every day.
How do you check?
I look, I look with my eyes. I look at them. And especially as I wash, take a bath.
You know, there's looking and there's examining. Examining is where you check there's a pimple, there's a dead skin, there's a lump, maybe it's swollen. You just check it. There's a, if you have kama kuna fungal, but checking you can just check whether they are clean and that's enough. So there's a difference. There's a time I was doing it, but it's kind of now I forgot. I was removing his dead skin and then the daughters took over, and then it's like it disappeared when they grew up. And for me, when I became busy, I think I forgot. Yeah. So unless he does it alone in the bathroom, but for me, I can't even remember the last time I did it for him. As a lady, like two times in a week, you concentrate on checking on your nails, the dead skin. The dead skin, you just you scrub a bit and see if there's something coming out.
Ai, daily. Kila siku.
Unaangalia nini ukiangalia miguu?
Nikitoa socks.
So what do you check?
Sinaangalia kucha alafu nijue kama miguu yangu kama nikitoa socks nijue kwanza kama zinanuka. Ndio mahali nimeshinda.
When I'm bathing.
How do you check them?
Si unainua tu mguu.
Nakata kucha, najisugua hivyo tu, hakuna kitu ingine.
My feet, I regularly check it.
How do you check them?
When I'm washing them, and maybe when I get injured, something like that.
Yeah, I keep them clean all the time.
How do you check them?
I wash them every evening and every morning. Yes.
You do it yourself?
Yes, I do it myself.
Do you do pedicures?
No, I don't.
Why?
I don't. It's not necessary for me to do that. Yeah, pedicures are for women.
How often do you check your feet?
Daily in the morning.
How do you check them?
By washing them.
Can you show us what you do?
What I do, when I'm in the bathroom, I scrub them.
Nainua tu naangalia tu hivyo tu kwa umbali tu hivyo.
While people do not take keen interest in their feet daily as they do other parts of the body, a minor problem with your feet may turn out to be so serious that surgery is the only way out. At Kikuyu Hospital's Orthopedic and Rehabilitation Unit, Ikline Nyangweso was just about to get corrective foot surgery, as narrated by Mary Mwoki.
When 48-year-old Ekline's foot started swelling, she didn't know that it might get to such a situation. She went from hospital to hospital searching for treatment. Doctors ran numerous tests, but none could satisfactorily establish the cause of her swelling. It was a period of deep anxiety for her and her family. Ekline, who has been living with diabetes for 3 years now, was not aware that her diabetes predisposed her to a condition known as Charcot foot. When a patient has this condition, the bones in the foot are at risk, and with continued walking, the foot eventually changes shape and gets deformed. She finally sought treatment at Kikuyu Hospital, where Dr. Ezekiel Oburu planned a surgery to correct her foot from this deformity to this, which will take her 3 to 4 months to heal. Although she is still recovering from the corrective procedure, she looks forward to resuming her life as she knew it before her foot deformity. A constant and thorough examination of your feet may save your limb from amputation. Eckline is lucky that she got help in time not to lose her left foot. Mary Mwoki, KTN News.
Prior to the surgery, Dr. Oburu took us through the assessment and preparation for the surgery and what foot and ankle surgery is all about.
I do quite a bit of foot and ankle. Maybe 25% of my practice is foot and ankle surgery, which is my subspecialty. So I correct quite a bit of deformities in the foot.
As we know, diabetes affects many aspects of parts of the body. It affects the kidneys. It also affects the nerves. But one of the things that it does affect is the feet. And what happens is these patients, because they don't have good sensation of their feet, they tend to get something known as Charcot arthropathy, where they get deformation of the feet. Sometimes it's not very painful, sometimes it has a little bit of pain, and this deformity just continues to progress.
Obviously, if you see a patient with a very badly deformed limb, especially after massive trauma, the patient would be in severe pain. You know, the patient would hardly be able to walk. But these patients, they have some form of function, and they're working on this very deformed foot.
First, number one, we do not know 100% how that does happen. However, one of the things that happens is it affects the nerves. And when diabetes affects the nerves, these patients, they don't have very good sensation on their feet. Now, for any normal human being, when they are walking or when they get hurt, they will realize they're getting hurt, they realize something's happened to their foot, and they'll tend to move. But these patients, they don't have that same sensation. And therefore, even when their foot is developing a problem, they don't react to it, they don't do anything to avoid this. That is what is postulated. This does not only affect diabetes, it affects other conditions that affect the nerves. However, the main cause really is diabetes because it affects the foot. The other conditions are not common. Some of them are conditions that may affect the spinal cord, like one of the conditions known as syringomyelia. One common condition that used to affect it in the past was syphilis. However, that does not affect it as much because this is properly treated. Some patients also that I have treated have presented with a Charcot foot without any prior history or any condition. If we look at her foot, this is her normal foot, and you can see her foot is quite a good, normal, supple foot. The ankle goes up and down all the way. And then we have a joint, it's called the subtalar joint, that enables you to walk on uneven surfaces, and that goes all the way. However, if we look at her abnormal foot, we can see, and we'll probably see this when she's standing. Maybe I can get her to stand. So we can see that as she walks, she's walking completely on the outer border of her foot. Yeah, she's walking and she's finding it very difficult to walk. And what I'll do is I'll get her to turn around. And you can also see that if you look her alignment of her foot, I'll just get her to lift her dress a bit. Unaweza kuinua tu kidogo. Kidogo, kidogo hivi. Kidogo tu. If we look at alafu kanyanga chini. So if we look at the alignment of her foot, we can see that on this side, the foot has normal alignment, but on this side, the foot is completely curved. There is what is known as a marked Varus deformity. Unaweza kuangalia hivi? So there's what is known as a marked Varus deformity if you compare the right side as compared to the left side. Unaweza kuketi. So I'll get her to sit because it's a bit uncomfortable for her. So the plan really for her is to do an operation that will at least enable her to be able to step on the foot. Now, the operation will entail making a small cut on this side. If you look closely, you can see that the skin is already threatened on that side, so obviously the operation is urgent. We'll make a cut on this side. We will remove some bone, and then we will straighten the foot. Now, the other problem with this condition is that the bones are not very good sometimes. And therefore, many a times when we do operations, what we try to do is we try to fix the bone in position with implants that are internal. But in this case, because the bones are not very good, we will try and use both implants that are internal, and we'll use an implant that is external. We call it an external fixator or a ring fixator. So we did some x-rays, and I will show you the x-rays over here. If you look at this x-ray, you can see that that bone is called the tibia. Okay, so the x-ray is in two views. That's one view, and this is another view. So this bone is called the tibia, and this bone here is called the talus, and that's part of the talus. And the talus, and this is called the calcaneus, or the heel bone. So that bone is crumbled up completely. All right, that bone is crumbled up, and maybe the blood supply is also not as great, but we'll see when we go in. Now, what happens in this condition is that you get crumbling up of this bone, or sometimes even bones around here. And what we are going to do, and you can see the foot is twisted that way. So my plan is to try and get that bone, you know, to get that, to remove this, the cartilage of the bone, all right, of both bones, and maybe to remove the cartilage of that too. Then after that, to bring the foot this way. Sometimes you have to get rid of the whole of this bone and fuse that bone to that bone. We do what is known as a tibio-calcaneal fusion. Not all of them are operated. Sometimes we just manage this non-operatively, especially patients with Charcot joints that are the midfoot. These are criteria for operating. In her case, this has been going on for quite a bit of time. The deformity is now at a place where it's not consistent with what she can weight bear, and therefore she will need surgical correction. There is what is known as acute Charcot, and there is what is known as something that's chronic or something that's established. In the acute, phase, sometimes you may have swelling of the foot, deformity of the foot, and when you examine them, sometimes you're not sure whether it's an infection or it's not an infection. One of the things which are called feet is that when you lift it up, the swelling tends to go down. That is what you may get in the acute. In the chronic, they usually present with deformities. It may be that the foot, the normal alignment is not there, and they may have what is known as a rocker bottom foot or a flat foot. And the other thing is that sometimes the deformity is much worse. When you examine them clinically, the patient is not in as much pain. Obviously, their neurology many times is compromised, especially if they're diabetic. The problem is the nerve supply. You know, your joints have what is known as pain fibers, what is known as proprioception sensors, and pain sensors. So when you get an injury, you know, you do get, you know, the foot tells the brain that, hey, it's painful here, and they bend. But these patients, because of impaired sensation, they don't have that, and they've got no sense even where their foot is, and so the foot may get destroyed. But we don't completely understand Charcot feet. Sometimes you can get one foot and that foot gets better, and then you get the other foot.
It's not that it's spread, it's just two independent disease processes. One of the worst complications is an amputation. So because of the abnormal position of the foot, you find that the patient may be walking on a prominent bone surface, or bony prominence. And when they walk on a bony prominence, you may get ulceration. When they get ulceration, they get a breakdown. When they get breakdown, they may get infection. And ultimately what happens is they may get infection, and that may lead to amputation of the foot. The other thing is also a loss of independence. These patients have got many needs. They're diabetics. They need to be able to get around. Sometimes when you can't walk, you can't get around. And the other thing is pain. Much as I say that some of them don't have much pain, some do have pain. And when your foot is very abnormal, it can be quite painful because you're putting a force or weight on areas you shouldn't be.
One of the things that will happen is that it will take some time for it to heal. I estimate it will take about 3 to 4 months at least for the foot to be able to heal. What you're trying to do is to get the bones of the joints to fuse, and obviously these are bones which you don't want to fuse because there's a joint, but you're trying to get the bones to fuse. Now, after it takes about 3 to 4 months, then she should be able to start walking. Yes. Although we will give her a boot because she's diabetic, they sometimes take much longer to heal. So we may give her a boot, but eventually the plan is for her to be able to walk.
One of the do's and don'ts when you do a fusion is to tell them not to weight bear, okay, so that you can allow the bone to heal. Some patients are compliant, some patients are not. Obviously, when a patient has got a frame or a ring fixator, that allows an element of play, but you still want them not to weight bear until it heals. So you'll tell them to use crutches for a while. For the initial fusion period, after a while, they can start putting weight on it.
The most important thing is the wound care. These are pins that are sticking out of the body, so sometimes you have maybe a chance of getting a pin tract infection. So you want to avoid that. So what we'll do is we'll ensure that the wound is taken quite well care of. Yes, until we are able, at such a time that we are able to remove the pins. I think the most important thing for diabetics really is sugar control. That is the most important thing. So, a diabetic foot develops after a while in patients with diabetes because of sometimes it's poor sugar control. So it behoves every patient of diabetic to take that diabetes to take that very seriously. The other thing is also they should always examine their feet, make sure that they don't have any sores, because this is not the only problem that diabetics have. They tend to have other problems in the feet, like infection and problems with poor circulation. So they should ensure that they're always doing a thorough examination of their feet. And when they develop a deformity, it's important for them to be able to see a doctor so that that deformity can be sorted in good time.
I love orthopedics. I love to operate on patients to get them back to their feet. I love teaching young orthopedic surgeons who are in training. It's my passion. But when I did my specialization in orthopedics and I came back to Kenya, and I found that, wow, many people are practicing general orthopedics. So I looked for an area where not many people were practicing and there was a major special need. And therefore I decided foot and ankle is a good area. So that's the reason. But I love foot and ankle surgery, I like the complexity. I like the challenge. I like operating on somebody who's not been able to walk because they've probably gone to many facilities and probably received no solution. It gives me the joy. And also, I have a passion for training young surgeons. I'm a lecturer at the University of Nairobi, so I teach young orthopedic surgeons. And, in any country, the next generation of surgeons must, go beyond the current generation. And many of my teachers who did a good job, they taught me orthopedics. But now it's time for us to move into subspecialties and for the next generation of surgeons to even become better than what we are. I see a myriad from trauma, people with broken bones in the foot, ankle fractures, fractures of the heel bone, fractures of the midfoot, fractures of the forefoot. I see patients with hallux valgus, that's bunions. I see patients with lesser toe deformities, that's hammer toes and claw toes and mallet toes. I see patients with arthritis of the midfoot. I see patients with arthritis of the handfoot. I see patients with flat feet. I see patients with high-yield feet, cavus. I see patients with Achilles tendon problems. I see patients with foot drop. Dr. I can go on for the next 2 days. You only have a limited period.
So before we examine the feet, let me ask, is it okay to wear high-heeled shoes?
Doctor, I don't know what it means by okay, but we wear many things that are strange, but we wear them nonetheless. What I would say specifically about high heels is I wouldn't say that there is any hardcore data that really points that people should be discouraged from wearing high heels. I would say, though, that in societies where people don't wear pointed shoes, like the ones we are seeing in front over here, people don't have what is known as hallux valgus, bunions. There is less incidence of bunions as compared to. So obviously all these pointed shoes, they probably contribute to some problems in the foot. And also, I think I just wonder how people are comfortable with them in the first place, even from a non-science point of view. But I think there's a balance between looking nice and comfort. I suppose maybe it's a price you have to pay.
Okay. So now when you're examining the feet, what are you looking out for?
So the first thing when you're examining the foot, I usually tell the patient to sit on the couch. Many patients would come and they would lie down because they're used to when they go to the doctor. I usually tell the patient to sit on the couch, and what I do is I come and I sit right in front of the patient. But even before they sit, the first thing that I do is I tell them to stand. Because when the patient stands, like in this case, then you're able to see various aspects of the foot, When they're sitting, the foot is not weight-bearing, on the ground, and therefore you cannot see some of the things that you're looking at. So looking at these feet, obviously you can see the beautiful painted cutex there, but that's not what we're looking at. But one of the things that is first obvious to you is we can see that there's swelling around this area and around that area. But in this case, you don't find the toes are deviated. So she has a bunion, which is swelling of that, but the toes are not deviated. That makes me suspect that there could be something happening in this joint. One of the things that you may get when you've got such a swelling is what is known as Hallux rigidus. Okay, so that's one of the things that I could be suspecting. I've not confirmed it yet, but that's one of the things that I could be suspecting. But you can see normal alignment of the lesser toes. Those are the smaller toes. You can see when she turns back and faces the back, you can see there's a normal alignment of the hind foot or the back of the foot. The hind foot goes slightly outward. You remember we said that it is in slight valgus. So one of the things that you can also see is that she doesn't have much of an arch. If I ask her to face the wall on that side, and you can see she doesn't have too much of an arch. It's normal. Yeah. So the foot can either be flat, yeah, where there is no arch at all, or it can have a very high arch. So those are some of the things that we look. Then the other thing that we do is we tell the patient to walk. So I'll just get the patient to walk forward. So the patient walks forward, and the patient walks back, So when you tell them to walk, for a long distance, in children sometimes we even tell them to run. And what you're trying to look for is you're trying to look for any deformity in walking. Are they walking on one side of the foot, or they're walking on the other side of the foot? You know, are they walking on the lateral edge of the foot, or they're walking on the medial border, or the, you know, the inner aspect of the foot, the medial border, or they're walking on the outer aspect of the foot, which is the lateral edge. The other thing you're looking for is, do they put little weight on the foot as they're walking, what is known as a short stance phase. We tell the patient to tiptoe, okay? And the purpose of this is to see if certain tendons are working. So when she tiptoes, you can see the foot turns inward, so it goes into valgus. That means that one of the tendons is working and the joints are supple. Then we tell them to go down. Sometimes we tell them to lift up one foot, or we tell them to walk on the heel. You know, that is also checking whether some tendons are working, especially tendons at the front. Good. All right. Then we tell the patient to sit. Tell the patient to sit down. And before we proceed, we ask the patient, is there any areas that they're having of pain? Okay. So it depends. You know, sometimes we zero in on that area. Sometimes it's what we examine. As long as you don't cause the patient pain, there is no problem. So in this case, one of the areas that she's complaining of pain is here. And what I will do is just gently move that forward. Now, upward. And, you know, she's got reduced range of motion on this toe. And when I move it down, she also has, well, down her range of motion is not too bad. But upwards, there's reduced range of motion. And I do that for this side. In fact, it's probably worse on this side. Okay? And going down on this side is worse. And straight away, and sometimes I may compress the toe there, straight away I can tell that she probably has arthritis of this joint. That is, arthritis of the first metatarsophalangeal joint, also known as Hallux Rigidus. Then we proceed to examine other aspects of the toe, of the foot. You know, one of the things that we do is to try and see, are they tight at their heel? And in this case, she is not tight at the heel. After asking for areas of pain, we examine the various joints. So this is the ankle joint that I'm examining over there, and I'm seeing if there's any pain at all in the ankle joint. Then we have another joint here. It's called the subtalar joint. We examine, and we always look at the patient's face when we examine, and both of those are fine. Then we come to the midfoot, okay, the region of the midfoot. And you know, we press there to see if there's any pain, press there to see if there's any pain, and all the way to the region of the forefoot. The other thing that we do is we check for range of motion. So with the ankle joint, you want to see if it goes up and down, and you're always comparing both sides. Then there is a joint known as the subtalar joint, and you want to check if that is flexible. In a case, they are very flexible. And then you want to look at the joints in the front of the foot. As we say, there's restricted range of motion in the hallux here, but you want to look at the lesser toes, which are fine. Sometimes we may zero in on what exactly we think the problem is. Like if there was a flat foot, we would check certain joints to see if they are painful. The other thing that we do also is we do a vascular evaluation of the foot. So we see. So what do you mean? Sorry, we check for the blood supply of the foot. And I can see there's one big vessel that passes here. It's called the dorsalis pedis artery, and it's good. And there's a vessel that passes at the back over here, and our patient here has got very good circulation. Okay? And sometimes we also check for whether the nerve supply is good. Like you remember in our patient who had a Charcot foot, you have to check for them. So you ask the patient, can you feel if I touch you here? And can you feel if I touch you there? That's checking for one of the nerves known as the sural nerve. Can you feel if I touch you here? That's checking for a nerve known as the superficial peroneal nerve. You check here and you check there. So you're checking various nerves. So those are some of the aspects of evaluation of the foot in general. Yes. Now, finally, apart from the nerves, from just checking sensation, sometimes you want to tell the patient to push. Push inward, and you're checking for the power of one of the tendons. Push outward, and you're checking for the power of the tendon up. Put your foot, push downwards, and put it upwards. Go up the way, and push upwards. So I want her to push up the way. No, you're pushing down the way. And you go up, good, and stop me from moving it. That's good. That's good. So I want you the same. Go up the way, push up the way, push down the way, push outwards, push inwards. And that's pretty good. Okay. Yeah.
So pedicures, would you advise people to do pedicures?
Well, I don't do them myself. I understand some men even do them. I don't think there's anything particularly wrong with them. Sometimes, though, if you are going for a pedicure and you've been going for this problem of the foot that's been there for years and years and years, it's not resolving. Sometimes it's an ingrown toenail. Sometimes the deformity of the lesser toes. Sometimes the callosity of this border here, or a callosity on the sole of the foot. Maybe you need to see an orthopedic surgeon to see what could be the problem.
That's hardening of?
Hardening, yeah. Callosity is hardening from callus.
So you advise somebody to see a doctor, not to do pedicures?
I would say that if it is something that's mild, that's recent, there is no harm in seeing a pedicure. But if it's something that's going on and on and on, and you're always going to the I don't know if you call them pedicurist or whoever, you're just draining money. There's nothing wrong with getting another opinion.
Okay. Then when you mentioned some of the issues you see, you talked about hammer toes and mallets.
Yes, and claw toes.
Yeah, how do they?
So a hammer toe, it looks like a hammer, and actually the toe is like that. And usually the patient will say, "Oh, when I'm walking, I'm having, I have something here, a corn." They will say it's a corn, and it rubs on my shoe. That's a hammer toe. A mallet toe, the toe is actually like that, So they may feel the foot is rubbing either at the tip there, the shoe is rubbing there, or it's rubbing at the tip here. And a claw toe, the foot is really carved in like that. Yeah.
And what causes this kind of toe?
Sometimes it can just come because of a local problem in the toe, but sometimes it can be something that's like patients who have got high arched foot due to a neurological condition sometimes.
Do people have smelly feet?
Well, one, I would say poor hygiene, especially men who repeat their socks 10 times. Their feet are going to smell, and they shouldn't ask anybody why. The other thing that I would say is you may get in between the toes, you may get sometimes a fungal infection. And that may be the cause of smelly feet. Some people also just have, sweaty feet, just like they have sweaty palms. And, with socks and everything, it may get smelly. Yes.
So should they do to avoid this, except the ones who are repeating their socks?
I think that, hygiene. Hygiene is important. You need to, if obviously there's a fungal infection, you need to have it treated. If you have sweaty feet, hygiene is important. When you get to the house, maybe you should just air your feet, For people with a lot of sweating, there may be one or two things that can be done, but that's really beyond the realm of, because it's a generalized problem, foot and ankle surgeon. I think the first thing is to just take care of their blood sugars. If you're a patient with diabetes, it's good to take care of your blood sugars. To be careful about what you eat, to follow your doctor's instruction. I am not a diabetologist. To make sure that you're not only doing sugars every day, but you're doing also something that will show chronic control or long-term control of sugars, HbA1c levels. So that's important. That's the most important thing. And also diabetics, if they get a foot problem, they need to examine their feet. They need to check in between their toes. They need to see if there's anything abnormal, and if there is, they should report to their doctor. By and large, for most people who are not diabetic, I wouldn't say that there's any specific instructions. What I would say, though, is that if you have a foot problem, it's giving you problems, don't assume that it's just a sprain or something you injured. It's good to seek professional opinion. There could be a solution to that problem. I'm not quite sure why people do pedicure. I don't do it myself. I think that they're fine.
And you know, you just have to be careful that when they're cutting your nails, they don't dig too much to the side. And sometimes what I would say, some patients have got what is known as ingrowing toenails, where the nail is growing all the way to the other side. And they have gone to so many people to do pedicure. That sometimes may need to be medically treated, where sometimes what we do is we remove part of the nail. We do what is known as a partial nail avulsion, which should be done by a well-trained doctor.
Naangalia hivi najua mguu yangu kama ni chafu ama kama ina harufu, sababu sasa venye nimeshinda na socks na labda kuna jua, lazima nioshe hiyo. Lazima nioshe hiyo mguu. Yes.
Wewe una examine na vidole ama
Na vidole naangalia chini na vidole pia katikati.
unaangaliaje chini?
Chini nafanya hivi. Yeah. Alafu vidole nafanya hivi. Yeah.
Hebu tuoneshe vile unafanya vidole.
Vidole nafanya hivi. Naangalia hivi.
So what do you check? Tuonesha?
Huwa naangalia makucha. Kama imekuwa refu. Na kata naona vile iko very neat. Alafu hapo pia naangalia katikati. Labda uchafu umeingia ndani, unatolewa ili ukitoa isiwe inanuka. Unajua ukitoa kiatu kwa nyumba na inanuka inaleta shida. Yeah.
Sinaangalia tu kama iko safi. Lazima uangalie kama iko safi, sababu usipokuangalia pengine uchafu iko ndio inaleta harufu nyingine.
Unafanya pedicures?
Si kila, si often.
How often?
Hata sijui. Sijui nikiwa na pesa.
Why should I do pedicures? I'm the only one who cares about my feet, but who else cares in Nairobi here about my feet? Yeah. The only person who should care for my feet is my wife and myself. And any other person who is in Nairobi looking at my feet should have other interest in me, which I not know.
I got nail cutters, and every Sunday when I'm free, when I'm with my Kenyasa, I pluck them off, my nails. I don't go to saloons or manicure. I do it at home on Sundays.
Why don't you go to a salon for manicure pedicure?
The same thing they do at home, the same thing they do at me at the saloon. Yeah. There's no difference.
But they're professionals.
They're professionals. They use only hot water, and me use hot water. And I scrub it with a nail brush. That's enough.
I always tell my young trainee surgeons that Kenya has got about 50 million people. That's 100 million feet, and that's about 1 billion toes. And the foot has about 26 bones. Okay? So if I add the number of bones, that's we're going into the billions. So, and all these can have problems. I'm not saying all patients have foot problems, but sometimes people don't know where to get help.
Your feet may be the most distal part of your body, but they remain just as important as any other part of your body. Constant and regular care for your feet may be what you just need to maintain your good health. This has been Health Digest. I'm Dr. Masi Korir. Keep your feet healthy.